And he always said, if we act in the interest of the public and our patients, and we're guided by science, we will not go wrong. So I just wanted to remember him. He died a few years ago. He was a colleague of mine at Dartmouth after he left, a mentor, I should say, of mine at Dartmouth, after he left his position as Surgeon General. I was reminded particularly of him today when I walked in the doors there and it said, the Police Standards and Training Academy is a tobacco-free campus. That wouldn't have happened 20 years ago, and that's in large part the work that everyone here has done and Dr. Kluge's solution in the past. So, moving on, it is my privilege. I'm very much looking forward to hearing our next speaker, who is Dr. Sharon Stancliff, who is from the Harm Reduction Coalition in New York City. Kevin Irwin is going to be facilitating the afternoon, and I'll let him give a bit more of an introduction. But I've heard of her for many, many years, and I've been talking with her this morning, and I'm really looking forward to hearing your presentation.
So this is a 1-hour session. We'll try to save some time for question and answer. Really grateful for Dr. Stancliff making the trip up from New York. Sharon has been the medical director at the Harm Reduction Coalition in New York, the National Harm Reduction Coalition, for the last 13 years. The easy way to introduce her is to say, if you want, there's a small handful of people who are top experts really in the world on the issues that she's going to address: naloxone, access, intervention, overdose prevention, and a little bit maybe on safe injection spaces. And we're really pleased to have Sharon here. Please welcome.
I can barely see her on the podium. I'm coming over here. Let's see. I just want to, following the syringe exchange presentation this morning, the reason I'm here today is because in 1992, when my patients were dying of AIDS they got from dirty needles, I went to visit an illegal needle exchange that was doing street outreach. And I loved it. I kept going back for years, and I hope I saved as many lives in my clinic as I perhaps saved there. So a lot of this stuff is just really fun. So I'm going to talk about some of the strategies to address overdose today, mainly about naloxone. We had fabulous presentations this morning on expanding opioid agonist therapy. I love PAP, that's great. I will let supervised injection facilities a little bit to make sure people know a little bit about them. I don't know how they would fit into New Hampshire. I bolded those three because that's where we really have the solid evidence that these have been associated with, these are associated with decreases in overdose deaths. The other ones we're hopeful of, and I'll come back to that at the end. But these three, I can show you data, and I will. Well, you saw the data for the opioid agonist treatment. Love the idea of PAP. One other thing I want to add to their presentations, though, I don't think anybody said how fun and satisfying it is to prescribe, especially buprenorphine, although as medical director methadone. People come back a week later and say, my life is transformed. I mean, it doesn't all end there, but 3 weeks later they might be bored. They had a full-time job of buying heroin. But the transformations that one sees, and eventually they go from being challenging patients to your easiest. So I'm going to do just a quick overview of what overdose is, make sure we're all on the same page. So opioids are miraculous drugs for relieving pain, diarrhea, cough, many things, long history of that. But the thing that we're really worried about when we're thinking about overdose is they depress the urge to breathe. Just don't respond to oxygen going down, carbon dioxide going up, your breathing gets lower and lower. And until we got fentanyl, it usually took a little while for people to die. So like even up to 3 hours. I'll mention a little more about fentanyl. But this means, there's something to do. You can stop this process. So I guess I'll mention fentanyl now. Fentanyl has other qualities to it that we don't totally understand, but one is muscle rigidity. And so you can see in the operating room that somebody's chest will freeze up and it's hard to ventilate them. And we're hearing a lot of reports in the community of this happening. If you forget everything else, naloxone works for fentanyl. It both works on the muscle rigidity and on the respiratory rate. If you just want people to breathe again, we need more naloxone in the hands of more people in the community rather than more naloxone in a few hands. We're really not seeing that people need tons of it, even with most of the fentanyl. So what does naloxone do? It reverses the overdose. So somebody goes from looking blue and nearly dead to breathing. If they had pain, they've got pain again now. If they are dependent, they'll be in some level of withdrawal perhaps, but very, very rarely violent. That's always a worry people have, and we just don't see it. It takes about 2 to 5 minutes to work, and it lasts about 30 to 90 minutes, which for most people is sufficient time for the body to metabolize the opiate and or the other drugs that were causing the overdose. That being said, we always say call 911, go to the emergency room, but for the vast majority of people, 1 or 2 doses of naloxone will do the trick. So we've got these formulations now. Here's a picture of the one that we're hearing about in the needle exchanges here. The one on the upper left corner is the sort of jury-rigged nasal naloxone, which has worked fabulously well in addition to the injectable that you see there for the year. So there's a couple steps to it, but it's worked really well. The lower left is a $4,000 product that talks to you, but then you can talk to your neighbor and then get one of the other kits. And then finally, this one is the latest Narcan nasal spray. That works very well, but it is a higher dose than what we're used to using and more expensive than the injectable. A little more expensive than the jury-rigged nasal, but I think it's going out of fashion. So in New York, we decided what are the essentials. This is what we want police to know. This is what we want pharmacists to tell their patients when they give them naloxone. What does naloxone do? What does it work on? What might be an overdose in progress? What does that look like? We teach them to do the sternal grind to make sure that somebody's actually unconscious. We have decided to call EMS or use naloxone first, whichever one comes to hand quicker. And we do teach the recovery position. So that's quick and dirty. If you're an outreach worker on the street, you've got 5 minutes with somebody that's using heroin. If you're a busy pharmacist that has a standing order from me or someone else, you can maybe get that information out. We really like for people to learn about risk factors for overdose. So this is what we hope will get taught. We want people to know that when they've been away from drugs for a while, they lose their tolerance, and a little bit goes a long way. I'll say more about that in a few minutes. We want people to know that mixing classes of drugs puts you at higher risk of overdose. So we talk about alcohol, benzos, even cocaine, and warning of the risks of using alone, because who can call. We have a very complicated Good Samaritan in New York State. I don't even like to talk about it because it's so hard to explain, but we kind of go there. Hands-on practice is not so important anymore since we're mostly giving out the easy spray. And then we decided that we couldn't decide whether we should train people on respiratory, on rescue breathing, or on chest compressions, which you can ask me about later. So we've decided that people can do either one. I mean, we don't know if somebody's identified an overdose correctly. We don't know if they will do mouth to mouth. So we basically have left it up to clinical directors to decide. I like to teach people rescue breathing at this point, but I can't give you good evidence that that's what is really going to work in a training. We know what you should do if you know what's going on, but what to train somebody in 10 minutes is the question. So from our little brochure, shake, shout, sternal rub, call 911. Probably say somebody's not breathing, but you might want to see overdose, so you make sure that somebody comes with naloxone. And get the naloxone right away. The labels on some of them will say, get the naloxone out before you call 911, and I just imagine people shuffling through their medicine cabinets, not being able to find it, whichever one comes first. Here's the pictures for giving the injectable, which, as we heard, people that use drugs can do that just fine. And I have taught people with great fears of needles when that was the only one available to be just fine with doing it. It's really easy once you practice once or twice. And then here's the pictures of how you do the nasal Narcan. The real pitfall there besides price is you can't test it. There's only 0.1 cc in there. That's not very much. So if you test it, the dose is gone. So we do worry a little bit about that. So in all cases, 2 naloxones are given out. Maybe you'll need a second one, or maybe you goof with the first, because it's scary thinking somebody might die. As I say, I tend to focus on rescue breathing, but it's acceptable for programs to teach CPR, or full CPR if they have time, but chest compressions only. And there are still people from Canada that yell at me from both sides. The United States is a little more calm about it, but there's some controversy internationally. We have 2 doses in every kid, because maybe that first one wasn't enough. And that just gets complicated in this age of fentanyl, because fentanyl does act a lot quicker. If you've got somebody not doing well, the temptation is to give the dose, and in fact, their advice is to give the dose about 2 to 3 minutes later. But it can take 5 minutes to work, so it's just a little complicated. Of course, it's better to be in withdrawal than to be dead. But withdrawal is not a great place to be either. Vomiting can happen, an aspiration of vomit. The likelihood of using again sooner may happen. The less likelihood of going for further help on that particular day. So I do get grumpy when the FDA frankly says, withdrawal is better than dead, just give a high dose and get them alive. I think all of you and all of our patients out there, most of them probably can do a little bit more nuanced administration. So this person's going to wake up pretty confused, maybe pissed off, and I'll show you, well, maybe I won't, but I've got some data on that. We ask them not to take any more drugs, but you know, if they're both grown-ups, I don't ask anybody to handcuff them to the chair for long enough. We just talk to them about it. We know that most people that are using illegal drugs are not calling 911. Some are, we have the Good Samaritan laws, but we ask people to stay with that person for at least 3 hours, which is probably a little overkill. If they're walking and talking, because that's how EMS does it in Copenhagen, then that should be fine. But if they're not okay, get medical attention. Besides calling 911, if you have a car, you can take them to the hospital. There's other ways of getting people help. And some people say, well, if they don't go to the hospital, are they going to get treatment? Well, in the hospital, in most ERs, you know, it's changing in some parts of the country. I think I'm sort of hearing here. They treat them and treat them. They watch them for about an hour, if the person will stay that long, and then they're out the door again. So until we really have a lot of good care in the ERs, I'm pretty much fine with this. So that's my brief overview of what Naloxone is, so that we're all on the same page. And now I want to think about some of the places that people can access it. Now, I'm going to be talking about New York. I do live in New York City, but a lot of my work, all of my work with police has been outside the city. And just by virtue of where they are located, all of my work with prisons is pretty much outside the city. Although I didn't know until I was doing it that there's 3 small state prisons in New York City. One of them is looking over Central Park, by the way, so I'm looking for it next time you're there. So anyway, I wanted to call your attention to this. I'm not sure if everybody's aware of it because it's relatively new. So the Centers for Medicare and Medicaid Services have said all Medicare Part D plan formularies must include naloxone. They've asked for it to be increased for Medicaid beneficiaries, and they've required all of the marketplace formularies to carry it. Now, it's a little, you know, I can't tell you about the different, you know, every state's different. I don't know if it always, sometimes it will have prior authorization or not. There are websites where that can be found. It's just one formulary. And then a really complex place on this is it just for Kevin, who's at risk of overdose, or is it for Seven, who's at risk of seeing Kevin have an overdose? That one's messy. Rhode Island has passed a law saying it's for everybody. Some of our Medicaid programs in New York are saying we interpret it as being for everybody. And I'll show you in a few minutes why it really should be. It's probably very cost effective if you like money better than lives. Just a quick run through. This has been evaluated not at all to the extent that needle exchange has. I'm going to show you the 2 studies that suggest that it really saves lives. But first it was like, would drug users use this stuff? Yeah, in fact, it came from a needle exchange. Well, it was first in Italy, but it came from a needle exchange. Just underline what Kevin was saying this morning. This is an intervention that came from people that use drugs for people that use drugs. And it's, until relatively recently, really been shaped by that. We do have studies that show if you teach people something, they remember it 6 months later, but I try to keep the teaching simple for that reason. We have studies that say no, people don't use it as a parachute. They're not likely to increase their drug use because they're carrying naloxone. I'll show you the ones on reductions in overdose, and it's been shown to be cost effective. It's distributed to a large number of people that use heroin, and I'll show you what money it seems to save if we get it into pharmacies as well. So in Massachusetts, early on in this, it was really hard to get money to study this. So that's part of the reason for the lack of studies. So in Massachusetts, where they've got a bad problem, they were rolling it out in various cities that had high overdose rates, and then they sort of stopped and took a snapshot and looked at where things stood in those cities. So they had distributed nearly 3,000 kits, and notice, most of the reversals that were reported by people who use drugs. They're very capable and willing to do this. And they found that compared to cities with no implementation, but that were similar in overdose rates, treatment rates, income, etc., that essentially this translates into if they had between 1 and 100 people per 100,000, 0.73 risk, so that's a 27% reduction in overdose deaths. If they got it out to a higher number of population, it was about a 44% decrease in overdose deaths. That's pretty powerful. When you've got a dose-related response like that, that says a lot. And then this is a more recent study where several clinics in San Francisco that were public, serving Medicaid patients, essentially, Medi-Cal, whatever, they asked the residents and the doctors there to prescribe naloxone to people that were getting higher doses of opioids or otherwise needed to be at risk of overdose. Some of them did it, some of them didn't. And when they looked back, the patients that got prescribed naloxone had a reduction of 63% in opioid-related emergency room visits over the course of the year. Now, those folks, many of them didn't think they were at risk of overdose. Like, ever had an overdose? No, not me. Have you ever had a problem? Yeah, they used Narcan on me 5 times because I goofed up with my medicine. Different language. But I think this is something, if you're friends with any insurance companies, please tell them this looks incredibly cost effective. It was not enough numbers to show a change in deaths. You have to have a lot of numbers. So now I'm going to go to New York State for a couple, how am I doing for time?
Fine.
Okay. I'm going to go to New York State for a few minutes, and as I say, a lot of this is rural. I realize that New York City is a different planet than most of New York State or New Hampshire, though I love it. Anyway, so in New York, this began at needle exchanges and moved on to drug treatment. So we now have we have a lot of more registered programs, but about 300 that are actively training community members. But all of the syringe exchange programs are a lot of drug treatment. It's kind of hard to penetrate there, and that relates to the prison work I'll tell you about. We're finally getting a couple of universities to be training their students. There's one in New York City, and then the Columbia School of Nursing is just registered as a program. By registering, that means they're covered, everybody's covered with liability. I'm not liable for what goes out under my orders, my standing orders, the trainer's not liable, the person who's using the kit's not liable. It's never been challenged in court, I don't think it ever will be. And also, most of them are eligible to receive free kits from the New York State Department of Health, which we're extremely lucky about. Basic life support didn't used to be able to give it, now they can. I'll talk more about the law enforcement distribution. I'm very excited about our correctional work, which I'm going to talk more about. Now it can be in schools, that was sort of an odd thing. And then, last but not least, pharmacies, they're the last ones to start working with naloxone, but I think I've really shown you why they should. So in New York State, every pharmacy is eligible to have a standing order for naloxone as long as they participate in our AIDS Drug Assistance Program, which is just the machinery, and I'll come back to that. So thinking of prisons, we know from the research that people coming out of prison are extremely high risk of overdose. Studies kind of range between 8 to 100 times higher risk of overdose, and most of it's about opioids. People just don't realize when they come out that how much they used to use is just even to get straight or to feel normal is enough to kill them now. Plus, when they've been away for a little while, they have no idea what's on the street anymore, and it's really different out there on the street. So we know it's a very, very vulnerable group, and this cool initiatives in New York was made up by one superintendent who's like, wow, well, it came from New York City, but it's like, on Staten Island, they're training people to use naloxone. Maybe they could come and train my correctional officers. And they did, and they thought, well, could we do the inmates, because they're all about to leave and go into this environment? And, you know, it required 2 people meeting at the Coke machine. I mean, it's sort of a series of who people knew is interesting, but Superintendent Dennis Breslin really initiated this whole thing by just looking around and seeing the problem. So, amazingly enough, the Harm Reduction Coalition is collaborating with the Department of Corrections and Community Supervision and the Department of Health to train every soon-to-be-released inmate across New York State in the state prison system, not in the jails, to use naloxone, and they are offered a kit on the way out. So we've got a video that you can look up, Staying Alive in the Outside New York. There's also one from Rhode Island. The pilot really, we kind of went to the facilities that the superintendent said were interested, and we mostly got people to volunteer to teach. A lot of correctional officers stepped up to train inmates, which I'm sure you know is probably unheard of. That's really shocked a lot of people. It's now being put into transitional services, and it will be taught by, what are they called? Inmate program assistants backed up by staff, and then the videos, the core training. So, you know, part of messaging is some of you may relapse or have a lapse, and we don't want you to die. Now, in drug treatment, they add to that. They want you to come back, but corrections does not want you to come back. They just want you not to die. But the thing that I think is way cool is we think you're a good enough person. You as a returning citizen can save somebody else's life. And I think that's also an important message in drug treatment. I think it's very, you know, people come out and they're calling themselves ex-cons, all these different things. I think that's a really cool message. So I only have the numbers from the pilot. It is now happening in almost all of the 54 facilities. Not all facilities actually release people directly. We used to have over 70 facilities, by the way. There's been some good changes. But there's between parole, where we do it in Brooklyn, and then the inmates from places upstate, there's at very least over 9,000 former, or 6,000 former inmates carrying naloxone across New York. There's also staff members, and that was a key point. We trained staff members first, and it turned out, you know, their families were so at risk of overdose, that made this a much easier program to bring in. The state can't afford to give all of the staff members kits anymore, but we have a solution to that. But that was really key. So, as I say, training staff first was very, very important. I mean, people would come up to me in rural New York and say, you know, at break time, and they didn't wait till every people walked away, and said, they tell me about their daughter, their niece, completely openly. It was just so much part of the landscape. We were really lucky to find an inside advocate, and of course he didn't do it alone. The medical director of the prisons, Dr. Carl Koenigsman, and the acting commissioner, Anucci, have both been really supportive. And I hope it rolls out well now that it's part of the job description, but I think it was really helpful to do it by volunteers at first. Now it will be, so we've had various reports, but the gentleman on your right is Kevin Small, who called us to tell us that he used his kit, so he's in the video. And to your left is, I'm so sad she retired, she was the director of parole at Brooklyn, and they're talking about using the kit. So we can't give kits to everybody anymore because it's gone from a $200,000 program to a $6 million program. But New York State came up with this idea of NCAP, Naloxone Copayment Assistance Program, in which the state's saying, well, we're paying like $75 per kit that we're giving out free. Copays are somewhere between $1 for Medicaid, and as high as they could go is $40. So why don't we pay the copay for naloxone? So you can go to a pharmacy with a regular prescription or no prescription if they've got a standing order, and as long as they participate in the machinery known as the AIDS Drug Assistance Program, this pharmacist will automatically be able to find that up to $40 of the copay is covered. Just began, it's a few months old, no data yet, but I think it's a really great money-saving option. I got so excited about that when I put it in twice. So I'm going to say a little bit about law enforcement. I'm just going to check the time. Oh, I think I'm okay. Let's say a little bit about law enforcement. This program in New York State had a different genesis, and I'm only talking about outside New York City, because this is overseen by the Division of Criminal Justice Services, and New York City has a different system, but the rest of law enforcement in the state is covered by this. So, when Basic Life Support started doing naloxone in a pilot, it turned out in one county on Long Island, some police officers were Basic Life Support and started getting their pictures in the newspaper for saving lives. So the governor decided, this is great, train the police right away. So we put together a training program really kind of quickly, and we did regional trainings. There's police who train other police. The barriers are much lower than in New Hampshire. Essentially, it's a 1-hour training. It's got PowerPoint video. It's been turned over to the police officers that are trained as trainers. That's one of their jobs, is being a training, so they take a training and then they do it. I don't have the numbers for how many have been trained yet, but we also took the chance to integrate a little bit about syringe access and buprenorphine and the community-based naloxone programs. I have some evaluation. That part didn't really get evaluated, though. This happened really fast. So again, it's just a really simple training. They may or may not know CPR. They may or may not have an ambu bag. There's 500 different police forces in New York State. So we kept the training really simple, and they could add on whatever they wanted to. So at this point, I was just looking at our reports. We've had over 4,000 reports of naloxone being administered outside New York City. In 48% of the cases, law enforcement was there at least 5 minutes before EMS was. We're mostly talking rural places, sometimes much longer. There's been a small qualitative evaluation, and they're all like, yeah, maybe it looked like I administered naloxone, but they all sort of pointed out it was a team effort. They do get some fatigue with people that have had multiple episodes of having an overdose reverse. You know, it's so hard, as I think we were hearing from the police chief this morning, when you only see the worst end of stuff and you never see the person who gets better because they don't stop by the police station or the prison or even the drug treatment program to see how great they're doing. They do stop by needle exchanges. But that's very frustrating. We need to sort of get some more feedback on some of the successes to them. So we've made these fact sheets, and they're pretty hard to read from there. I didn't intend you to. But one thing here, we haven't had a huge increase in people needing more than 2 doses, and this is the low dose, old intranasal naloxone. So my point about it works for fentanyl, because Erie County is full of fentanyl. The other thing is that we've had about 3 or 4%, it's on there somewhere, described as combative when they wake up, but not a single incident report has been filed. Combative essentially means kind of flailing around some and not just grumping. So we've not had any incidents of violence. There was one against a fireman where his neighbor beat him up for using naloxone. But as it turned out, he beat up his neighbor often. So you know, it's, yeah, you've got that personality. So now I've just got a little time to talk about supervised injection facilities. And my point is not, you know, I don't know if they fit in New Hampshire. I hear you do have some places in some cities with a lot of public injection. But my main point is to let people know really kind of what they are, because there's a ton of misconceptions. Yes, I am an advocate for them, but I'm afraid some of the advocates for them have kind of even spread the misconceptions, because it's really one small part of the solution. So these are places where people can go and consume drugs that they've obtained elsewhere. They're not heroin replacement treatment programs. People get their drugs wherever they're getting them, usually by injection, because it's sort of hard to do this whole smoking thing, having people staff around people that are smoking cocaine or heroin. That's complicated. But it's an environment for safer drug use, to improve the health status of the group being served, but also to reduce public disorder. And as I talk about the ones that are legal around the world, it makes me remember I'm here at the police academy. In all of the ones that are legal, there was law enforcement, community members, all sorts of people, sort of like we began to hear about when the needle exchange is opening today. There's a lot of similarities. You really need to have people on board in order to have legal supervised injection facilities, because it crosses a lot of lines. It can be done. I mean, if you've got a lot of people injected in the park and in the McDonald's, It's not that hard sometimes to get the community support to say, let's get it off the streets. In fact, it was suggested in a meeting once where real estate people, well, people that wanted to make money in real estate, were vehemently opposing having a needle exchange on the Lower East Side. Why don't you just open a place where they can go inside and inject? And his colleagues were like, shut up, shut up. And all of us needle exchange people were like, great idea, we'll get them all off the streets. So it's not it's a radical idea, but it can come from many, many things, whether you want public order or safety for the people served. So it was initiated in Switzerland a long time ago, in 1986. It's now in at least 11 countries. I haven't updated this slide since mid last year. France has just opened. Canada is expanding rapidly because of the fentanyl. I'm hoping to go back to Montreal and see the one that opened last summer there. They're doing pop-up ones in Vancouver and Toronto because of fentanyl being there. So those, of course, will have less services, but I'm going to show you there's a lot of services in these. So there's a variety of models. Most of the ones that are legal have medical supervision, generally a nurse with maybe a physician somewhere on call. That's been the case at all the ones that I've visited. And non-medical. There's, I think it's closed now, but there was one that was in the basement of the church, and it just had people around in them. They can be closely integrated with other sites. If you go to the one in Vancouver, Canada, it's like, oh my God, why don't people talk about all these other things? The drug treatment, the detox, the places to stay. There's multiple services. Sydney, Australia is standalone because of political reasons, but there's services just down the street. And there are some mobile ones in several places. So we heard about mobile needle exchange, mobile buprenorphine this morning. There are some drug consumption rooms, and I don't know that those are medically supervised where people can also smoke, but when I was just recently at one in Norway where they were trying to figure out how to get the ventilation together and how to sort it through. They had it partly set up, but they were kind of nervous about the next step, and I was talking to the nurse, and she was excited but nervous. And there's underground supervised injection facilities in this country, one of which has actually had a study done on it. Well, you know, it was very small, but they found similar results to those that are much better evaluated. That one is in an undisclosed location. But commonalities, usually these are created in areas where there's a lot of public consumption of drugs. All the ones that are available, that are out there now, as far as I know, are in larger cities, not huge cities, not New York City, but larger cities than say Ithaca, New York, which is looking at this. They can't really find a model that kind of goes to the city of 30,000, but they do have a public injecting area where they really feel like they need to get people off of the streets. As I said, they're always developed in conjunction with public health, law enforcement. It really does need to be a collaborative effort. Some of them require a certain amount of evaluation, some of them require age, where they live, but I think there was a model where people are not going to get a car on the bus and go across town, or often, as far as we know, get in a car and go somewhere to a supervised injection facility. I may be wrong about that, but it does seem like it's sort of local. They all have links or direct contact with other services, and most of them separate out the injecting area from the places where people are waiting or following the services. A review of the existing ones finds that they serve a fairly narrow, important, but a narrow population, men in their 30s, with a lot of problems going on. Frequent housing insecurity, job insecurity, unemployment, history of incarceration, participation in sex work, many already have HIV or hepatitis C, and a history of a non-fatal overdose. So far, to my knowledge, we don't have any that are serving the 19-year-old that just began using drugs. This is serving a really marginalized population, which I think, how we serve a marginalized population says a lot about how we care about public health. But it's not the only answer to overdose. I think it may be an answer to overdose in some places for some people. This is a picture of the one in Vancouver where you go and sit in one of these little, oops. How did I go somewhere? There you go. That's a booth where you go and sit. There's a mirror there, so the nurse that sits behind you can make sure that things are going safely. The nurse, and most of them will not inject you, but she might, or he might come and say, well, that looks like a better vein there, or don't lick your needle, or lots of little tips like that. But they're harder to teach if you're in a needle exchange where you're just handing over the needles. Vancouver has been studied and studied and studied. There are not very many, like, oh my God, we have to do it this way studies, but the preponderance of them in showing reduction, in showing connections to healthcare, shorter stays in the hospital from soft tissue infections, access to housing, they all add up to a very strong body of evidence. And rather than just have the whole list, I thought I'd show the one that relates to overdose, since that's my thing today. So this study, I should have looked at it again, had overdose rates in the immediate area around where the supervised injection facility was to be sited compared to the rest of the city of Vancouver. And what they found was, before the SIF was there, they had 22 per, a 88% rate difference in overdoses from before they opened the supervised injection facility to after they did. That's really phenomenal. But what happened in the rest of the city? Maybe overdose went down everywhere. They had a much, much smaller reduction in rates of overdose, like 6%, I mean 6 less. Can you see those numbers better than I can? No. Okay, I'm sorry about that. It was a really phenomenal increase in overdose deaths in the immediate area of the SIF, which is where everybody was injecting, compared to the rest of the city where there was much, much less injection. So I think that's the main evidence that there is. There's also a lot less ambulance call-outs for overdose in Sydney, Australia. So no one strategy is going to be effective for reducing overdose deaths. And honestly, I don't think we're ever going to get to zero. I think that's really hard, but we can go a long way down. We need the opioid agonist treatment. We need PAP. I love it. Yeah. We need naloxone access. We need to be thinking of other strategies that are proven, including supervised injection or consumption facilities, which remain illegal in this country. And then we need to be evaluating the promising things that are coming out, like the long-acting naltrexone. Prescription drug monitoring programs are showing reductions in prescription drug deaths, but in most of those places, the fentanyl is just taking over and taking it up. And we still need to be evaluating the judicious opioid prescribing and what that does to people that are already dependent. Okay,
That's
So I'm pleased now to introduce Chief John Drury from my neck of the woods. Chief Drury is from Farmington. I've only been here 3 years, but every time I go somewhere in my region, Opioid Task Force, the Addiction Summit, Prevention, Treatment, Recovery Roundtable, I talk to folks. I see Chief Drury there looking for solutions, supporting solutions. I talk to a lot of folks in the recovery community up in the Farmington area who are looking for solutions. They always say they're well supported by Chief Drury and his force. And I know that he's led the way on finding ways to get naloxone to the folks that need it, and really pleased that he's here with us today.
Thank you very much. I want you to take a moment to think about being a little different. It served me well. About 18 years ago, I came here and was scared to death, and was proud to walk across this stage after my academy. And but on the first day, a cadre came up to me and said, "You're from Farmington, huh? Are you going to see it all?" And unfortunately, they were right. There are a lot of good ways, and unfortunately, a lot of bad ways. My town they're suffering through some tough times. We've had it really difficult. For a town of 7,000 people, last year the police department handled, through our dispatch, over 16,000 calls for service. That could be, and we're only a 14-person department. Then that could be anything from someone looking for directions to, unfortunately, a double homicide we had last year, or a double shooting we had last year, or another shooting that we had last year. We've really, we've had a tough time. We had a guy break into a house to rifle through someone's prescription cabinet and shot the homeowner. Fortunately, we ended up having a good ending to it. He wasn't very seriously hurt. But, you know, our violent crime has gone up. It wasn't a day 17 years ago I'd go to a bar fight, no big deal. You know, now unfortunately it's gone to something much more drastic, and you know, our officers are seeing stuff that they never would have seen before on a tough scale. And you know, you look at going to revive somebody for the 5th time, there is a bit of atrophy there that, shoot, we're doing this again to Johnny, and when will Johnny learn? But we've also got to remember that Johnny's someone's son, or someone's daughter, or someone's father, or someone's mother. And I think we've started to get past that. So when I say think about being a little different, I don't want you breaking any of your policies. I just want you to think outside the box and to work with people. When was the last time you took a walk in your community? Talk to someone at the store. Sometimes we just rush in and grab what we need and rush out. So I try and have my officers walk the downtown, meet people they haven't met, get a tour of a building that they haven't seen. We've got a bank in town that's a labyrinth. I mean, it's a bank that was built a long time ago. It was built upon. You go down there, there's sub-basements and stuff. It's really cool. So I encourage our officers to get involved in the community and to check out things that they may not are aware of. Let your troops do something a bit different and be open to ideas. I have an officer that comes in probably once a month to me and goes, "Hey, Chief, what do you think of this?" And I'm like, "Hey, you know what, we can do that, or maybe not yet, but let's keep it on the back burner." We've had to get really creative in Farmington. We've had pancake breakfast with Narcan. I never would have thought I would have seen that. We've had Narcan in the park, you know, where we were able to get people to learn about how to administer Narcan, and thanks to Dean and all of these groups that have helped us. We've started coalitions in town. The Friends of Farmington's Circle of Hope, SOS Recovery has helped us greatly. Ava's Goodwin and all of the outreaches that we've been fortunate enough to have. Educating our public with forums to dispel fear and stigma has been huge. The drug courts in New Hampshire that work with people, but also hold them accountable for their actions. That's the biggie. I want to work with people, but you know, you do have to pay a price for something you did. But once you've done that, let's forget it. It's water over the dam. Let's get on with your life. Let's make something of it. And we'll help you do that. I remember one time a guy came and I had arrested, and frankly, I'd completely forgotten about him. And he came up to me probably 6 months, 8 months later, and he showed me, he opened an envelope, and it was his first paycheck. And that was nice, that we were able to get somebody on the right track. And it does happen, it is out there. We team with our fire department and other local groups to get the public involved. Offering these classes to our officers has also had good benefits. Several have become interested and can administer Narcan. That's one thing I do want to touch on is we need to make it easier for our officers in this state to get Narcan and be able to administer it. I just finished my research last month in December, and holy mackerel, it was a challenge. And I'd like to see that somehow become easier for our officers, because last time I knew it statistically, there's not a lot of officers in the state that are doing it, and I'd like to see those numbers increase. Affording your citizens the opportunity and the availability to make a difference in their community by learning CPR, first aid, and how to administer Narcan is so important. And I've got to remember that it's 10% of the population that we deal with 90% of the time. Those 10% can be challenging sometimes. But therefore, there's 90% of the people that we seldom see. those people that are working hard and out there trying every day. And we've got to try to remember those people and to educate them. We have discovered that by involving the public, who are our eyes and our ears of our community, we have not only saved lives by helping people that are overdosing, but people have approached us and given us information that has led to arrests of the people supplying our community with the poison of illegal drugs. You can get out there and talk to your people in your community. They'll let you know probably more than you ever wanted to. But they'll give you that information, and sometimes you can use that. Farmington's a tough community because a lot of our people go outside our community. They come back in with just enough for a day or two supply. They sell a little bit to their friends. They use a little bit, and their friends won't want to tell on them because they're their supply. So it's a close-knit community that they have. But sometimes we can get into that and find out where they're getting it from and disrupt that. Narcan is great. It gives a person a second chance at life. And we are present, it gives us a moment to intervene. When someone wakes up and looks up after being revived, it's a real shock to them that the chief of police just saved their life. In that instant, I can suggest that they get help. I usually carry some cards with me of some places where they can go and get help. I try and give those to the family and as well as that person. I'm not there to criticize them. I'm not there to, down on them at all. I just want to see them get help. Because if I can do that, maybe next time I won't have to be here. And you'll be on your way. Our town numbers have slowly reduced. In 2015, we had 12 deaths from overdose. 2016, we had 4, and in 2017, we had 1, but unfortunately, I think it's going to probably turn into 2. That was late at the end of the year. Now, granted, Narcan, we've given, has risen. I don't know what the numbers are for my EMS, but I'm sure they're going up. It seems like at least once or twice a week, we're out on a call administering Narcan in the town of Farmington. But we've had these people get out of addiction and thank us for helping them. A woman that one of my officers helped came, and she had her child taken away because of her overdose, but she was able to recover and get the child back and now leads a productive life. I see her quite often, and it's good to see her doing so well. If you ignore this problem, it's slowly going to invade your community, and before you know it, you will see a spike in overdose, you'll see a spike in deaths and drug-related crime. I won't bore you with the statistics. I was shocked when I looked them up. 52,898 people in 2015 nationwide, 64,000 last year. And it's too much, but 37,000 people lose their life in traffic accidents, and we're almost double that now with overdose deaths. Looking to the future, that means this next decade in this country is going to see possibly 500,000 drug-related overdose deaths. And I know in my town alone, everybody knows someone that's passed away. By the time I get done talking, 2 people in this country will have died from a drug-related overdose. A bad year in New Hampshire is 100 people losing their lives on our roads, but yet over 400 do it in overdoses. And some medical examiners I read in Ohio and out that way, they don't even have enough room for the bodies, unfortunately. It's overtaken. I know it's difficult to change our own minds on this matter. Scrooge said to decrease the surplus population. I had to remember that these are someone's sons and daughters, fathers and mothers. And we're not part of the, if we are not part of the solution, then we're part of the problem. And I'm tired of being part of the problem. I want to be part of the solution. We've done a lot of good things in Farmington. We have a lot of long ways to go. And this state has done a lot of good things. And I am proud to be a member of this state in trying all the things that we do here. I've got 2 sons that are 19 and 21 years old that I fear for. Both have good heads on their shoulders. They're clearly from their mother's side because they're studying engineering. But in Farmington, like I say, we try to go out of our way. We've offered rides. My officers have given rides to Manchester safe stations. That's a great idea, and it seems to be working really well. We try to check up on people. We try to offer some services. Our own community has trained coaches, and we try to offer their services in a safe environment. Our churches have opened their doors to offer counseling. Volunteers have stepped up to help. I know for a fact we can't save them all, so we can make it a little more difficult for them to get that supply that they're trying to get. And looking in the future, we're also trying to get them the help that they need. It's tough. In a rural community, there's not a lot of services out there, but there are a lot of friends. And if we can even just get them to talk amongst themselves, we've seen progress. As I said before, in Farmington, a lot of people drive out of town to pick up their supply of drugs for themselves. They sell a little bit to their friends. They support their own habit. It's tough to catch them, and looking at that bigger picture, I know the poor city of Lawrence has been suffering, and they have all these people coming into their community, and we get statistics that show when one of my residents is arrested out of state, and I'm like, son of a gun, I didn't know that person was into drugs. So we are forming a much more of a community statewide that is helping us keep an eye on our population too, to see where our drugs are coming from and where we can better fix that problem. These people, unfortunately, steal from their friends and their family. We're hesitant to tell on them until finally enough becomes enough. We've let our community know it's okay to work with us, and it's probably going to save someone's life. Several people that we've arrested in these cases now lead productive lives, and understand if it wasn't for the intervention by their family, they may have died. It's tough love. You know, I'd much rather not arrest somebody. It's a lot of paperwork. But there comes a point when the poor family they're at their wit's end. And the arrest is going to be the best thing for them. At least it gets them into the system. It gets them possibly involved in the drug court. Our drug courts in Stratford County, and as I understand the state, are really holding people accountable. And once they get through that process, they can get over it and get on with their lives. In closing, to prevent the opioid deaths, the best advice I can give you is to get involved. Have your staff get involved. Community police like never before, and trust me, it'll pay off when you need help. I mean, we have community police in this town for a long time, and I was blessed that our residents bought us a new public safety building this year that we really desperately needed, and I'm very proud of it. And it shows that just to be involved in your community, it's so much nicer to walk down the street and talk to somebody, know them by their first name, and be open to their problems, and they'll listen to yours too. Debrief. Even your first responders need to take a break, especially if it is that fifth time you just Narcan Johnny. It is really true. Sometimes we get into a funk and we don't mean to. We're there to help people. Whenever I hire a new officer, one of the first things they ever say is, hey, what do you want to do? I want to help people. And it's almost guaranteed what they'll always say, I want to help people. So by trying to get them out in the community, it's allowing them to help people. The people that are overdosing in this country are becoming a lost generation, and they're dying at a rate that has surpassed wars and traffic accidents. Trying to get out of the mindset of, well, no one is forcing them to take drugs, it was their choice, and trying to get into the mindset of forgiveness and recovery, innovation, and importantly, building good cases for prosecution when you can. If we in law enforcement, fire, EMS, nurses, and doctors, and the public don't get involved, someone else clearly will. And we will see these people again and again, but only if they're lucky. Thank you very much.
Does anybody have a burning question for either Chief Drury or Dr. Stancliff? Or both?
We can come up and
One question. And then while we're doing this, I'm sorry to interrupt you just like that. Could everybody from our next panel please come on up?
I see cases where some people need like 3 to 5 rounds of Narcan to be revived. Does that necessarily mean that they had a higher dose of fentanyl or heroin. Can you speak to that? Because I would think that it would be about 1 or 2 doses, but I see a lot where it's maybe 3 to 5 for them to be revived.
Well, a lot of times when we explore that, we find that people are giving doses in really rapid succession and haven't allowed for enough time to elapse for one to work. The second thing we find is what is the endpoint you're looking for? Say this person has been drinking, taking benzos and opioids. They may actually not, their restoration of respirations, the fact that they're breathing, may not be well recognized. So we don't always have enough information, but when I talk to some of my toxicology colleagues, it's like, yeah, they actually drowned him in naloxone and he barely taken an opiate, so it was this, and that. Now, I don't want to say that there aren't such cases out there, but we're really trying to explore those because we don't want to mistake a need, what appears to be a need for a lot more naloxone, which is unfortunately very expensive, for the way that, and I don't want to pick on anybody. It's scary to think somebody might die, so I'm not going to say, oh, you shouldn't have given naloxone that fast. It may seem like it took an hour to give 5 doses and it took 5 minutes. But I think we do need to look fairly closely at the cases. And there probably are a few out there, but I think that those are kind of the exception.
Did you have anything to say about that, Chief Jerry?
I'm sorry.
Did you have a perspective on that?
No, I agree. I have seen, an unfortunate circumstance we came across was a gentleman that had been incarcerated. You touched on it earlier, was he got out of jail, he took the same dose he was used to and overdosed. And he was one of the reasons that we really have been trying to get our public to call is no one called for him. They left him on the unfortunate side of the hotel and he passed away. And so, unfortunately, the fentanyl and the heroin is getting stronger and stronger and stronger. So if they relapse and they take that same dose, as you said, they, unfortunately, it almost puts them into an overdose very quickly. And that's one of the reasons we've had some community outreach is just call us. We don't care. We want to save that person's life and get that, start the ball rolling on the help that they need. I think I've seen 3 doses of Narcan administered at one time. But as I think about it now, it was pretty quickly when it was done because they didn't come out
Right.
very quickly. And but it was a similar situation. I don't think he knew what he was taking or the extent of it or the amount.
Thank you both.
It was a pleasure.